I'm Chris Malaisrie. I'm a cardiac surgeon at Northwestern Medicine and faculty at Northwestern University. Thanks, Dr. Saraja, for inviting me. Thanks to the panel for putting up with a cardiac surgeon at the panel. So wish you had sent that patient to surgery. This is going to be an aortic valve and valve complication. I call this this is forever memorialized in my brain as the TAVI, TVAR, TAVI case. So rich emotional experience. Okay. Lots of disclosures. Here's the case. So she's 73 years old. She's had a bicuspid aortic valve in the past and previously underwent an aortic root replacement, a valved conduit, so a 23 millimeter bovine pericardial valve and a 28 millimeter Dacron graft in 2004. She's having symptoms. She's got some comorbidities. She's got severe aortic stenosis, and other valves are okay. Coronaries are fine. STS is 3, frailty is 1. We thought she was high risk for preoperative AVR because it was a previous root. It was a little bit harder to do. So pre-op CT scan shows a fairly tortuous aorta. We do these cases under monitored anesthesia care, so no general anesthesia, hybrid CCL anesthesiologist in the room. It was a tough case to get around with the Medtronic valve. We switched the Confida to Lunderquist wire, finally got it around. So this is about 80% deployment here. So it's a 23 peri mount. We're trying to put a core valve 26 in. I'm doing this with Mark Ricciardi sitting at the back table over there, grinning, I hope. So we're at 80%, and the implant depth is about 10 millimeters. We're pretty happy with this. So we go ahead and deploy this valve. It's moved a little bit. Now we're about 1 millimeter deep, and we're still pretty happy with this. We're letting the fellows get some gradients, and we're planning for a second case, and we're not happy with this one right now. So we're about minus 10 depth here, and of course, right about this time, you wish the patient was under general anesthesia because she says, "Oh, doc, my back hurts now." So just a mild AR. We pull her off the fluoro scan and take her down to CT, and of course, there's an aortic dissection here with a contained rupture. So we take her back. This time, general anesthesia, hybrid OR.
Where do you think the rupture was?
I think it's...
Where does that plan on your aortography? Because I don't see it on the aortography.
I don't see it on the aortography either, but I think it's as we're pushing the catheter around the descending aorta. So you got that S-turn. It's happened that S-turn just distal to the left subclavian artery.
So you don't think the migration had anything to do with it?
No.
I mean, the valves.
The Evolute has a nitinol shaft to it, and then it has a little nose cone. And sometimes coming around a tortuous arc, there's a little bit of a separation that can hit. That's why I was wondering if it was kind of right at the great vessel takeoff origin there.
Right, right.
And then the next generation now that's all on our lab shelf actually has tightened up that nose cone nitinol capsule separation, so it won't separate anymore. But I didn't mean to interrupt. I just think it's a great example.
So we take her back, we put this Gore C-tag in, and we're doing this whole case. The wire's in the LV because I want to get some support here, and just hoping that valve doesn't move anymore. So we're able to deploy this as a zone 2 landing. Pretty happy with this deployment. We've got 2 devices in there right now. TE shows it's more like severe AR now, so we go ahead and put a second valve in. We don't want to make the second mistake twice here, and I'll tell you why I think this happened. So we go ahead and put an Sapien 3 in. Pretty happy with this deployment. Now you see 3 devices in there. So she does okay. She's got this funny configuration now, 2 valves in series. You guys can explain to me how this is bad for the coronary circulation diastole. But in terms of indications, this is what guidelines say right now for a failed biprosthetic aortic valve and valve. So the patient's high risk or prohibitive risk, Europeans would call it increased surgical risk, class 2A recommendation. And I think Dr. Chattrawalla talked about this. The downside with valve and valve is gradients. So out of both trials here, both Sapien and the Medtronic trial showed mean gradients of about 17. So those are no one seems to believe me when I say that, so I have to show this slide. And Danny, it's too bad Dr. Dvir is not here, and it seems to be worse in smaller valves, maybe worse in the Sapien valve. AUC criterion just came out. Bob Bonnell authored this one, and valve sizes are coming into play here, and you see that, you know, the default is always redo surgery. That's always a green light. But if you got a valve 23 or greater, it's probably okay. It's always appropriate, never appropriate for 19 or less, and maybe appropriate for 21. So I think the indications are correct. But the big question is, well, why does this happen? I think Mike Reardon can understand this, but you got to respect the valved conduit. So on the left side there, you can see that there's a Dacron graft, and it's a little bit short. And distal to the Dacron graft, there's a mandatory anastomosis there. It's a little bit slightly dilated. And that conduit's a little bit short for this particular patient. And you can actually see what's going to happen here off that angiogram. The anastomosis is the valve is not sitting all the way into that conduit. So what's going to eventually happen is the waist of the core valve is going to find that middle anastomosis, and that's what I'm trying to show you in that last picture all the way to the right. So I think that's why it's migrated. Be glad to take any comments from the floor. But in conclusion, I think this case proceeded according to guideline recommendations, high risk and prohibited risk. Alan Zaharis is trying to study low-risk patients with a valve-in-valve trial with an Edwards Sapien 3. Complications here, we had a valve embolization, and we'll throw in a little bit of aortic dissection and rupture. So the treatment was a TAVI, TAVI case. The key learning here is respect that valve conduit in patients who had a previous aortic root replacement. And if you ask me if I would have done this surgery, I probably would have still tried to do a TAVI for this case. But I know what the hospital would say, though. Well, guys, you spent about $75,000 of equipment. Next time, operate on this patient, please. Thank you very much.
You know, I found there's often a kink. Sometimes, I don't know, maybe if it's not done correctly or whatever, there's often a kink with those conduits, and sometimes the core valve, you have to almost guess at how it's going to lie in there and whether that's going to leave you canted sometimes. But
so the question I had was that you had a CT scan and you saw this thing, so why core valve? Why didn't you put a Sapien?
We wanted to do core valve because we thought we'd get better gradients out of it. And we didn't pay enough attention to the length of that Dacron.
Because it is, as you would have done with the post-dilation, you could potentially get very similar gradient. You just showed the data showing that both had similar gradients. So the question, because of the flexibility of the delivery catheter, sometimes if the aorta is so tortuous, I prefer not to use. And if you have a constriction on the top of it, again, the same thing, you could have potentially predicted that the core valve will not expand, as you say. And with the kinks, so many people have kinks with the Dacron ascending grafts.
So a couple things. We used a lot smaller, I think the valve sizes, was a lot smaller with the Evolut and our Evolut continued access or expanded use study. So I don't know if we can line up gradients per gradient because we'd have to look at the size of the valves, which might be different. But second thing is the Evolut doesn't require to have any contact to the aorta whatsoever. So I think that there's something that was going on at the inflow, at the site. It looked like there was a little bit of an incomplete expansion at the inflow down in the valve, and unless there's full expansion, you don't get the full radial strength of that. So I think that the problem was really at the surgical valve inflow interface with the Evolut, and not because it will sit right in the middle of the valve, and it doesn't have to touch anything. So I'm not sure that the interaction with the aortic root was, or with the aortic graft was a big problem.
And it does, it looks curved in, because we've deployed them on just leaflets only, not even, I mean, they've often been like -2 and they stay, so it does look a little funny at the
And
bottom.
it was
I'm not sure.
moving a little bit outward too. So Mike, what do you think?
So, well, a couple things. First of all, that's a really funny looking graft. You almost never have to do a root on a bicuspid valve unless it's a young person with AI, not an old person. And usually that's when you do the ACE in the aorta. And somehow only half the ACE in the aorta got replaced. So it starts off, there's something wrong when you look at that picture as a surgeon. And the second thing is Chris, there's two ways you can do these valve conduits. One is you can put the valve up in the graft and leave a little graft hanging down and sew the graft to the annulus. Or two, you can sew through the valve itself. If you sew through the valve itself, your only option is to do a whole redo root in an old person. If you sew the graft to it, you sometimes can just replace the valve and put things back in. Do you know how it was done, Chris? Was it done where you're going to have to do the whole root? Because these can be really complex in these old people.
Right, yeah, this surgeon put the sutures through the graft as well as the valve. So I knew this was going to be a tough redo.
Great.
Good, thank you.
Thanks. Let's